Okay, hi everyone. We're about to get started. Both doctors are here today. We're going to do one question, one follow-up. We have 30 minutes. I'll turn it over to the doctors now.
Thank you. Good afternoon, and we'll talk about some of the numbers again today and how that works out. Some of the things we're trying to do with segmenting the long-term care data from the general population in that regard, and some of the other analysis that we're undertaking at this time. So before we get into that, I'm going to hand things over to Dr. Yaffe for the numbers today, and then we'll comment on those after that's over. So over to you, Dr. Yaffe.
Thank you. So good afternoon. As of 4 p.m. yesterday, in the IFAS system, we have a total of 15,728 confirmed cases of COVID-19 in Ontario. This is an increase of 347 cases, or 2.3% from the previous report. And so that is down from an increase of 525 the day before, and I'm certainly hopeful that this downward trend will continue. We have almost 58% of our cases are in females, almost 45% are in people 60 years of age and older, and 59.2% are people who live in the Greater Toronto Area. We do continue to see an increase in the number of Ontarians who have recovered from COVID-19. At this point, 61%, or 9,612 of our cases are considered resolved. Unfortunately, we have seen the number of people in hospital increase to 977, but the number of people in intensive care has decreased again today to 235. Of those, 186 are on ventilators. And tragically, we do continue to see deaths related to COVID-19. To date, 996 deaths have been reported, which represents an increase of 45 deaths from the previous report. With respect to what's occurring in long-term care homes, the Ministry of Long-Term Care is reporting 159 active outbreaks in long-term care homes. 775 deaths have been reported in the residents, and 1 death among staff. I know there's also a strong interest in data on retirement homes. So for the first time today, Public Health Ontario has included information on outbreaks in retirement homes in its daily epidemiological report. From that report, which is again data from IFAS, Integrated Public Health Information System, we know that 67 retirement homes have been or are currently in outbreak. So that's a cumulative number. We have 419 cases have been reported in residents of retirement homes, 223 cases among staff, and 77 deaths, unfortunately, among residents. We are also working with our colleagues at the Ministry of Seniors and Accessibility on the availability of their data. Similar to how our colleagues at the Ministry of Long-Term Care receive data from their long-term care homes, the Ministry of Seniors and Accessibility as well receives data from their retirement homes, and that is often more timely than the data in our IFAS system. In terms of the laboratory testing, at this point we have tested 264,594 tests have been done. Currently 9,530 are under investigation. In the last 24 hours, 11,554 tests have been completed. And the number of healthcare workers who have tested positive is 2,193, or almost 14% of the cases. Again, this is a cumulative number. This is not necessarily those who are currently ill, but it's the number that have been ill since the beginning. Thank you. So I'll turn it back to Dr. Williamsdale.
Yes, well, thank you. And so, as I said yesterday when you had that jump up with a number, I said take that with a grain of salt. Let's see how it goes with our numbers overall, because the lab specimen inflow from especially the number of testing taking place in the long-term care facilities is not consistent. It ebbs and flows. As you can see, we still have 9,000 tests pending, which means they've arrived after midnight. And last night when this data was compiled, and they're being undertaken right at this time, and more arriving as we speak. So with that in mind, because you've been asking a lot of questions about how does this data relate to long-term care homes, how does it relate to community-based ones. And I possibly before, in my calculations there, and I've asked for some more detailed ones, that was probably about 50-50. And now having looked back at some of the more detailed data from our people at the Public Health Ontario, it looks like going back to when the data is complete, each day is somewhere between about 47 and 55% of the cases are long-term care in that. And so that means, again, about 50% around that range approximately is from the community side. So that's good news in a way, because when we were up at the 600 level, we had around perhaps 300 in the community. When we dropped down to the upper fours, we're in about the 220, 230 level. And one might get very optimistic and assume today with the 347, although I'm going to say that's probably with a lab data flow issue and entry, that we'd be even under 200. So I'd like to think that would be the case. But I think from that perspective, you've been asking on that. And we may see that percentage that the long-term care makes up of that number increase over the next number of days as we continue to undertake a full testing survey of the long-term care residents in there. But that depends on the positivity rate and how many we're finding in the homes that, one, do have outbreaks or some that don't have outbreaks. And so far, it looks like on our broad base ones we've done so far, the actual rate of positivity is still not bad, around 3%. But we have to watch that and monitor that as we go through the wider range of homes and cover that over the next number of days ahead of time. And that no doubt will put an extra load on the lab testing capacity as we start to ramp it up even further over the next number of days into the weekend in that aspect there. So we have those. And we also have that our positivity rate overall is again back down to the 5.7 level. It was down to 5.5 before, went up and went down again. So that's a positive direction, that it continues to come down in that regard there. And our so-called R naught, we call about it. That's the measure of spread, is reducing down. Remember, we wanted to get that well below 1. It's actually, for the average of Ontario, is right at the moment is at 1. So it's progressing down because we were higher, and even last week we're at 1.2, 1.3. So for those who like to know that number, that is improving as well. So all indications are we're moving in the right direction. Nevertheless, we continue to drive at doing more surveillance in that way with our long-term care homes, looking at retirement homes, and we're also now looking at congregate settings and how we might undertake that task as we look at that one as well. And as you heard from the Premier, he also is wanting us to do some surveillance and set a plan in place for looking at our childcare centers that were opened up for essential workers to assess that situation, since there has been an event, a potential outbreak at one that Toronto Public Health is investigating. And so on a proactive basis, we've been requested to look at how we might undertake to do a surveillance, if you may, of the staff at these facilities to ensure that that's not the case of the staffing, and that the to ensure the safety and the concern of parents, especially essential workers, in the expanded list as announced by the Minister of Education, who would want to access those services and want to be assured that everything is in place, not only does the staff are not infected, but also that all the guidelines put out by the Minister of Education on the webpage are being adhered to as far as proper infection control practices in those settings. So those are the main things, the details for today. So with that, I'm going to hand things over for questions.
Okay, we'll move to the phone lines.
Your first question comes from Mike Crawley with CBC News. Please go ahead.
Hi there, doctors. We're looking ahead to the weekend, and at least in the Toronto area, the weather is expected to be really quite nice. There's lots of evidence about how risky indoor transmission of the virus is. What do we know now, or what do you know now about the evidence about the relative risk in outdoor spaces that's been informing your advice to people to stay inside?
So we have had that report some at our Federal Provincial Territorial Committee. in there, and it's predicated mostly on, again, having some aspects related to the physical distancing, so that generally people outdoors will have more space to be apart from each other. But some people think, well, since you're outdoors, you're going to have a crowd of people, 10 or 15 gathered together. The evidence does not support the benefit of doing that. So again, as I said before, a lot of our things, if we're going to look at some of those activities, it's going to be, yes, outdoor, but, and that means small groups, less than 5, usually a family unit, the so-called bubble, I guess some people use that term, or pod. And you can do that kind of activity. The large gatherings and that, if you're outdoors walking, try to keep that 5 or that 6 foot difference. And to honor that, there is the use of facial covering for those who might feel they could get into a situation where they are in a bit of a closer proximity for a short period of time, to have that extra protection. So in general, outdoor means it depends what you're doing and what setting you're in, and how you can maintain that social distancing. Someone asked, do I still use that word? And I like to use social distancing too, because because the physical distancing is the actual distance. The social distancing, I feel, is a Canadian way of being polite and saying, it's not that I'm concerned about you, I don't trust you. I'm doing it as being a polite to walk around, so I'm not going to try and expose you, even though I don't have it. It's just a matter of Canadian courtesy and doing that. So in that way, I think outdoor has to be put in the same context and under the same guidance in that way.
Follow up?
Are you concerned that sort of sending a more blanket message to people to not go for walks outdoors risks undermining the public goodwill that you've built up in this crisis? I guess I'm trying to get at whether, how clear the message should be about whether it's okay for people to go for walks or not, and what kind of an impact that's having, because I've spoken to a lot of people who are feeling like the message has been, you need to stay inside, don't go out for walks.
So I think, and I agree with you, I think with the amount of public cooperation, how everybody's done a great job at this, that on a weekend where there's good weather and stuff like that, I know it's very hard for people to stay inside. My recommendation is, if you're planning to do something, activities, then you need to plan to do them, and plan them in such a way as that you don't compromise yourself by losing that physical distancing. Therefore, you don't go to places where you think everybody else is going to go. You don't go out hours where everybody else is going to go. And you plan your outdoor walk and that kind of thing in areas that are less populated than that, so you spread it out, if you may, through politeness, because some may say everybody wants to go to that walking path, and if you have a walking path that's fully packed, there's no way you're going to maintain physical distancing. And if you all go at the same time of the day, that's not good either. So I'm not discouraging people from going outdoors to do something, and some would go out and do their jog and run, but you'll do that in areas where you can seek to maintain your physical distance in that regard, and plan it. So that's why the planning part is important rather than on a whim, because if you have the whim, you're probably going to do the same as 5,000 other people, and you're out doing the same thing in the same place. That's not the plan. So, but I'd like people to think about that they could do those things and plan those, because as we continue on this, people have a bit of cabin fever in that, and I want to have people continue at the task on to go forward, and we're going to be looking at a number of things that we can do to ease some aspects without compromising our public health safety in that way, because it's only but reasonable that during the weather people want to do a few more things, but how can you do it in a safe way and can be consistent in that manner? So encouraging activity that is safe and encouraging people to stay at the task is all part of it.
Next question.
From Ryan Rocca with Global News. Please go ahead.
Hi there, doctors. And just kind of staying with the theme of the nicer weather coming up, the Premier has previously told people to avoid going to the cottage during this time. What risk does someone pose if they go to the cottage? They might have the virus, but they sort of self-isolate in their own residence up there.
So, yeah, there's been much discussion, debate about this one here, especially as the numbers are coming down. We're not quite there yet. And looking at that aspect there, The point that we're trying to understand is some of the local leaders in the community, some of the mayors, and with we're asking the local medical officers of health to look at that and to make some recommendations. The concern is that those individuals coming up, are they coming up to now reside in those areas for prolonged periods of time, especially before the usual cottage time of the end of May in that regard. And so therefore they're worried about increasing the population of their community where they haven't yet ramped up the spring resources of both the facilities that are there as well as hospital staff and locums, etc., and that they might come up and potentially bring COVID into the community where they have not seen it at that time, or they may have been in a very low state, perhaps negative for a number of days or weeks now. So we're trying to ask our public health measures group to look at some aspects around there. And again, the aspect they're trying to wrestle with here is asking Ontario citizens to be, I guess, be responsible. And that means if you don't need to go up, then you would prefer you didn't go up. And we're trying to wrestle with the people feel, well, they really have to go because there's some concern about their property. There may be some report of some damage or issues. There may be insurance requirements. Can you do that in a way that, one, that you're not staying for prolonged periods, you bring your own supplies with you, you're not sick, and you're not in bad health, and you plan to go and do that essential task in that short period of time and come back again? And that's what we're hoping to be able to say, can we do that? Is a way that people will do it responsibly and respect the local communities and the local mayors, etc., that they feel their community is not going to be compromised in any way. And so we're trying to look at that, how that might work. And of course, it really depends, much like our other measures, even in Toronto, when we talked about going out on the weekend, will people continue to be vigilant and concerned about the physical distancing even while they're doing some of these more outdoor activities? We would like that. We would ask that, and we expect people to be responsible in doing that. So we haven't put out a wide recommendation on this as of this time, but I know the Premier's being asked about that and others about, especially as you get closer to the so-called official cottage opening time, and that's a different issue altogether. They're talking about people going up even in April and May for some reasons, and we're trying to address what's the best recommendation and how does that fit with our local public health units and local community leadership, trying to respect each in their own perspective.
Follow up?
And can you just touch a little bit more on what risk it poses to the healthcare systems up in more rural areas if all these people start going up to their cottages?
Maybe
you answer that.
I'll chip in on that one. I think, first of all, I think there's some concern that people coming from the Greater Toronto Area, where the preponderance of infections exists, may have an asymptomatic infection and bring it to that community where they haven't had very much infection. So that's one concern. I think another concern is the healthcare system may not be equipped to deal with the number of people that come in terms of the number of hospital beds, the number of ICU beds, and the number of ventilators. So I think they are concerned that there would be demands put on the local healthcare that may not be able to be met. And the concerns around supplies, and Dr. Williams mentioned, if you're going to go up, bring your own supplies, because maybe the grocery stores aren't equipped to deal with that many more people at this point in time. So those, I think, are the main concerns.
Next question.
Your next question comes from Allison Jones with the Canadian Press. Please go ahead.
Hi, Dr. Yaffe. Yesterday, the numbers you were able to provide for retirement homes are different than the ones today. There were quite a few more deaths you mentioned yesterday. I think those must have been the ones you mentioned that come directly from the Seniors Ministry. Do you have any updated ministry numbers for retirement homes rather than from IFIS?
Yes, I do, because I thought somebody might ask. And it's a similar issue to what we have with long-term care, where we have the two different databases. And so for retirement homes from the Ministry of Seniors and Accessibility, the data shows, and I think it's active data currently rather than cumulative, which IFIS is, 61 outbreaks, 593 cases in residents, 263 staff cases, 117 deaths, and 20 outbreaks resolved. So the numbers are different. For example, deaths, there's 117 in the ministry database as opposed to 77 in Yaffe. So again, a challenge that we're trying to address to bring the two databases together and figure out what the real information is.
Follow up?
Thank you. Yes, I was just wondering for either of you, I know you've spoken about looking at assessing when childcare could reopen, and that one of the factors is sort of assessing how the emergency childcare centers are going. Does the fact that there were some cases in one of the City of Toronto emergency childcare centers, does that affect your assessment of when all childcare centers might be able to open?
So, yeah, part of the consultation we had before when they were planning to expand to a larger number of essential workers and actually open up more sites was to say up until yesterday we had no events reported to the currently open sites over their nearly 2 weeks or 3 week period they've been open. So this one here we just found out about, and that Toronto Public Health is just undertaking the investigation at this stage. We still need to be informed as to what their investigation will tell us related to this specific incident. Is it a one site issue? Is it a systemic issue or not? Do we know? But I think on a more of a proactive basis in that regard, because of the importance of having these available, and for the recovery type process, the Premier has asked us to consider putting a plan together where we would at least assess the staff involved in these locations, both at this time and in the future. So we're going to look at those ones there and put a plan for it, but we still want to be informed from Toronto Public Health investigation as to where the index case might have been, where the linkages are, the case contacts, etc. So it's still in their first 24, 36 hours of investigation. So we're going to be informed by their work if that tells us of anything further. And then do we have to put further things in place for future child care settings in that regard, knowing that for a lot of the recovery processes, many couples require, if they have employment, require child care services. So we want to make sure if they are going to be available that they are safe and we haven't increased the risk of any further community spread, knowing that children historically, up to data thus far, have been low as far as any risk in that area, but it's not really one that's been highly researched. So we're going to look at that information carefully in conjunction with Toronto Public Health.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hi, doctors. I'm just following up on some testing stuff that I was asking yesterday. So a month ago at this newsroom on March 31st or March 30th, we heard that the testing goal was 19,000 a day by mid-April. So here we are, it's late April, and we've only cracked 12,000, I think, on 3 days. So why is this continuing to lag, and what gaps need to be filled in to do so?
So, I think one we've done is that at the assessment sites, we're trying to watch to see our numbers. If we've widened it, that anyone who is symptomatic and a wide range of symptoms can go and get tested. So that is basically a voluntary basis. If people want to do that and take part. So we can't force people to go. They have to do it on their own volition. The other side we're trying to work on there, we did our first wave of doing our enhanced surveillance testing of all staff and the residents at the long-term care facilities. We undertook to do first the group of so-called red zone group, or some with outbreaks, and we wanted to sense how much would that add to our capacity. So we're going to get some more numbers again tomorrow. We were concerned it might really push us too fast, but I think we're okay, and so we can enhance that even further and ramp up our testing even more. So that will probably continue to push us up towards that higher number. So it was a combination of carrying out priority testing as required by the, in this case, the incident management group for long-term care homes, and doing that, and we've done our first phase. Now we have the rest to do, so a lot more testing to come, and that will continue to put the numbers up. And that's part of it. And now we have also the childcare added to it, and then we also still have pending our anything related to retirement homes and also with congregate settings. So much testing to get done. It's a matter of getting all that out there, getting done, getting the material in, and making sure we're doing it correctly, making sure we're documenting it correctly, and because in the end you have to do some analytics and analysis, and we can't afford to waste those tests. We will make sure they're done accurately, timely, correctly, and reportable in a proper way. So I think we'll get there. I hope we don't push it over the top, but we're going to do our best to utilize that capacity as best as possible.
Follow up?
Yeah, thank you. And just to follow up on that, what happened to that 19,000 number, that target? Because now I guess it's 14,000 by the end of the month, and I think it's 16,000 next week. So what's happened with all these numbers, and why can't we go higher? Like, are we limited by reagents? Are we limited by swabs? What's holding things up other than procedures?
Well, I think one is the targets that we hope to get by doing the testing from our consulting group and the whole network one. They're still hanging fairly firm to the 19,000 capacity in the system, so they're holding that there. We're trying to give ourselves basically place markers to get to achieve, and then ramping up our testing to use that capacity and not just do it in a haphazardous, like move towards and keep upping it, as I said. So we're trying to put that as targets for ourselves to utilize, but certainly from our consulting group and from the network, they still feel fairly confident in the 19,000 as a system capacity.
Next question.
Your next question comes from Cynthia Mulligan with City TV. Please go ahead.
Hi, Dr. Williams. I'm hoping you can help me out with some numbers here. So, of the 347 positive cases released today or revealed today, 297 appear to come from staff and residents of long-term care homes. So that would be 85% of the new cases just released today were from long-term care. And yet I know the data is sometimes comparing apples to oranges, but does that seem right? Because that would be 85% of the cases coming from long-term care. And would that possibly be because the emphasis is on testing in long-term care?
There's a yes and no. The yes is your arithmetic the same as mine because I add up the LTC numbers. It's 297. But as I was asking for our people to look at the segmentation of the data points, as they're doing that, they know that the IFAS entry dates are not strictly on the day of entry. So some of the 347 were ones that are entered that were actually tested 3 or 4 days ago. So it's just like a running target going up there. So my conclusion was initially like yours to say the 297, that leaves that only a few were from the community, and that was probably on false pretense. The actual numbers that say by about a week ago, that testing pretty well has all the entries in there as a more of an accurate number to make sure the completion of the IFAS entries from all the points and sources are there, so it's more realistic. So that, for example, a week ago, when we had about 510, about 490 of those were actually recorded. There was some number adjustments in there, and then that was about 50-50. So I think what we want to say is that maybe in a few days from now, how does the 347 work out, and is the arithmetic, as you and I did quickly, correct, or is it probably going to be more closer to about 50-60%? So maybe more in the range of, say, 190 were from community and the same amount from long-term care. But I think what you got to, and I agree the same, as we're doing more and more of this surveillance, it should start to move up and not only make 50% of the number, but 60 and 70%. So maybe of the 347, our number for the community may be actually even lower, but it's premature to make that conclusion at this stage because the data entry is not synonymous with the day. This is 347 is the number of positives over the previous report. That means some of those could come in over 3 or 4 days mixed in there as they're coming in. So each day the IFAS says the new positive added to the old total is this amount. But some of those may have been even some as late as 4 or 5 days ago that finally got put into the database. That is the challenge of using it as an accurate, by-the-moment reporting, but certainly as it goes back for about a week ago, that data is pretty well 95% complete, and then we can use that analysis. But the trending I've seen over the number of weeks before is it usually has been around 50-50. But I think as you're hinting, as we go forward with the survey, we might start to see that trending going more like 40% community, 60% LTC. So let's see what happens. But I agree with your math, but we both are jumping to the same conclusion and a bit premature.
Follow up?
Thank you. Yes, my other question is, before we start opening up the economy, shouldn't we start random community testing so that we actually have a sense of how many people are out there that might have it but are asymptomatic? I mean, we seem to be targeting our testing, but it doesn't really give us the big picture.
You or me? Go ahead, Barb.
I'll start, and then I'm sure you'll have something more to add.
Sure.
I think that's an excellent question. And I think our public health measures group probably will be looking at that. One of the things that I know that the lab, Public Health Ontario lab and the national lab have been looking at serology tests, and serology being blood tests to look for antibodies. And there are some issues right now. They're looking at the validity, how much, false positives, false negatives, all this kind of thing. But if we can find a good serology test, that would be the best way, I think, to look at how many people actually have been exposed to this infection, doing what they call a seroprevalence study, and taking blood tests from a random set of people and saying, what percentage of people have evidence of antibodies to this virus in their blood, i.e. they have been exposed to this infection. That would probably be the best thing, in my opinion. But of course, we could also be looking at random testing. But then, people have to be willing to have a nasopharyngeal swab and they're feeling fine. So we'll see how that would go. But I think, definitely we need to start looking at that in addition to the targeted testing that we're doing.
Yeah, as Dr. Yaffe said, I probably have some more comments. And in a way, by doing our survey, a good of the 87,000 residents in long-term care facilities and another 140,000 staff, none of them are not in outbreak mode. So they're like general public in that sense, doing a test. So let's see what we find. And that would be another warning, especially a group that could be more susceptible. The challenge you have is that, as Dr. Yaffe is alluding to, if you do a study now or in say 3 or 4 weeks and do a sample of 1,000 people, and you find that there's only a few positivity rates, does that mean that the rest of the people were never exposed? You can have someone who was exposed 2 months ago who's negative on the test, but a serology test would say they are immune. They were exposed. So the test is only a point test at that time, and a negative tells you only what they are at that moment. They could be positive in the future, or they could have been already positive in the past and you didn't know it, and they have adequate immunity with evidence of infection. So I agree with Dr. Yaffe and others who looked at that, saying if we're going to look at population exposure, a serological survey may be more useful and more informative rather than a random survey of people. But we're doing a lot of healthy asymptomatic people. Right now, we've engaged to do a whole bunch of staff at some childcare centers, and we're doing some more. So these are people not in an outbreak mode, but are members of the public anyway. So we'll continue to be informed by all these different ones and utilize the data as best as possible and wait for an approved serology testing if we're going to look at population exposure.
Okay, we'll move to the next question, and this is going to be our last caller.
Your final question comes from Randy Rath with CHCH TV. Please go ahead.
Hi, doctors. I'm wondering about when we're talking about opening up the economy. You've said that the daily numbers have to go down for 3 or 4 weeks in a row. Are you referring to, do they have to go down every day, or is it a weekly average that they have to go down?
Yeah, I mentioned this yesterday, and again, say we're looking at a trend, and it never goes down. Well, it'd be nice if it went down smoothly and steadfastly. That'd be easy to predict, but it tends to have little bumps and blips in it because of the flow of lab data and reporting and data, stuff like that. That's why I said yesterday that jump up all of a sudden to over 500. Let's just take that with a grain of salt. This jump down to 347, take it with a grain of salt. It may not be going like this. It may be in the overall average. So I think what you're getting to is that what can we say on a trend analysis, and that's more what our public health measures group would be looking at, including what our modelers would look at. Is it a continuous slope in that? making up for the blips and little variations in day to day. So it's like a weekly average, but drawing a straight line through all the different ones to say what is the overall trend. That's what we're looking for.
Follow up?
Continuing with opening up the economy, because there's such a prevalence of COVID cases among frontline healthcare workers and workers in long-term care and retirement homes, as we open the economy and go through the different stages, are those workers going to have to continue to self-isolate because they may risk starting a second wave in the general population?
So if I want to make sure we're clear, the workers that are identified positive will isolate. That's true. If you're saying workers writ large, in that, do they have to do that? A number of the healthcare settings have ongoing monitoring of their staff, and if there's concerns, they will test them if they need to do so. But the fact that they're using proper personal protective equipment, and especially if their facility has had no cases reported for a period of time, there's no reason that they would have to be limited in their access to the rest of the if we open up some aspects. But remember, we said we're trying to maintain the social distancing so that they can't say they're going to go out into large group gatherings. No one's supposed to be doing that. And so then how do they do that in that context? So I'm not sure did I answer the question I think you're getting at? I think, did it cover that?
Yeah, well, just is there more of a risk for those people to participate in society than there is for, say, somebody that doesn't work in those settings?
If it's an outbreak setting, yes. If we have closed and resolved that outbreak setting, the answer would be no.
Okay, thanks everyone.